Hello, I'm Dr. Jeffrey Hayes, Education Specialist of the American Society for Reproductive Medicine. Welcome to this presentation of the ASRM Grand Rounds webinar series. These webinars are designed to address topics in the ABOG Learning Guide in Reproductive Endocrinology and Infertility. Today's presentation is by Dr. Clarisa Gracia. Dr. Gracia is Professor and Director of the Fertility Preservation Program at Penn Fertility Care at the University of Pennsylvania. The title of her talk is Current Achievements in Fertility Preservation and Future Directions. I will now review the details of today's presentation. After the webinar is done, please do not forget to return to AIR Learning to take the post-test and complete the survey for your continuing education credits. You must complete the post-test questions successfully and complete the survey to receive credit and be able to print off your certificate. If you have any questions for our speaker, please send them to education@asrm.org, and we will forward those questions to our speaker. We're very excited for this presentation today, so I will waste no more time and now turn things over to our speaker.
Thank you so much for that introduction. It's really a pleasure to be part of this initiative for ASRM. And as we mentioned, today's presentation will be on the topic of fertility preservation. So first, I'd like to disclose that I have been the consulting epidemiologist for ASRM and am on the ASRM board. So the objectives of today's talk are first to discuss the potential indications for fertility preservation in children and young adults. I'll describe some of the evidence regarding the success and safety of current methods of fertility preservation, and we'll talk a little bit about the data on egg freezing and ovarian tissue cryopreservation in particular. We'll discuss some of the gaps in knowledge and future research directions in fertility preservation. So there are a variety of potential indications for fertility preservation. We see many women facing fertility-threatening treatments such as chemotherapy and radiation therapy for the treatment of cancer, as well as other medical diseases like lupus nephritis, sickle cell anemia, and thalassemia, just to give a few examples. Some patients require removal of the ovaries for the treatment of cancer, for ovarian tumors, or to prevent the onset of cancer in the setting of BRCA mutations. Transgender patients are now more often seeking fertility preservation consultations and services as well. As part of my practice, I'm seeing a number of individuals who are transitioning from female to male and considering ovarian suppression during adolescence to suppress pubertal development prior to initiating androgen therapy. Ultimately, some of these patients consider oophorectomy, and ideally, it would be possible to cryopreserve gametes prior to the initiation of some such therapies, especially if a carrier is considered in the future. Females with conditions that predispose them to ovarian failure are also candidates for fertility preservation. In an era of increased genetic testing, we're also seeing more girls with genetic conditions such as Turner syndrome who present very early while ovarian function may still be present. And finally, the fastest growing group of women seeking fertility preservation includes women who are worried about infertility related to the natural decline in fertility with age. As you know, there have been incredible advances in technologies available for fertility preservation over the past decade. This slide presents an overview of assisted reproductive techniques available to females. First, we can stimulate a woman's ovaries and retrieve eggs and freeze mature eggs. Alternatively, we can stimulate the ovaries, retrieve eggs, fertilize them with sperm, and cryopreserve embryos. Or we can have a patient undergo limited or no ovarian stimulation, collect immature eggs, mature them in vitro for subsequent oocyte or embryo maturation. And finally, With no ovarian stimulation at all, we can freeze ovarian tissue, which can subsequently be used for transplantation or potentially for in vitro maturation. It's important to recognize the pivotal role that vitrification has played in fertility preservation. In the past, gametes and embryos were cryopreserved using slow freeze technologies. And you should know that there are two methods to freeze eggs or embryos, either slow freezing or vitrification. Slow freeze essentially is a process where low concentrations of cryoprotectants are used and gametes or embryos are slowly cooled in a programmable freezer over several hours. Alternatively, vitrification is a rapid process where cells are exposed to high concentrations of cryoprotectant and then plunged into liquid nitrogen. And we routinely now use vitrification for freezing eggs and embryos, and this is felt to have led to significantly higher survival and better outcomes with assisted reproduction. Embryo cryopreservation is really only a good option for committed couples. Embryo cryopreservation, as you know, has been around for a long time, and we know that it works very well. It appears that the transfer of previously vitrified blastocysts leads to live birth rates at least as good as fresh embryo transfers. When you look at national IVF statistics, it shows that the success of frozen embryo transfer is about 45% in women less than 35 and declines as women get older. There have been a couple of lawsuits now regarding embryo ownership in cancer patients, and so it's important to be aware of those, and generally embryo cryopreservation really should only be used in couples who are truly committed and are at low risk of separation in the future. I think we can all agree that by far the biggest achievement in reproductive medicine in the past 5 years is our ability to freeze and thaw eggs. This has, for the first time, allowed us to provide females the option of preserving their fertility without having a male partner. As you all know, in 2013, the ASRM published a guideline after review of the literature and stated that egg freezing should no longer be considered experimental. It was recommended in patients facing infertility due to cancer therapies, and at that time, caution was advised for the use in elective egg banking. In this study, over 500 donor egg recipients were randomized to using either fresh or vitrified oocytes. Over 90% of the frozen oocytes survived the thawing process, over 70% fertilized, and overall, 55% of patients who had a transfer became pregnant. And this was no different than when fresh oocytes were used. So again, this was really an exceptional study demonstrating really for the first time the effectiveness of oocyte vitrification, at least in the egg donor population. Indeed, most of the data on egg freezing success comes from egg donors. This has been the impetus that really moved the technology forward. Banking eggs like sperm obviously greatly facilitates the process enormously, in that there is no need to coordinate recipient and donor cycles. There's less risk of cancellation since the eggs are already frozen. The donors can be retested and eggs quarantined like sperm to avoid sexually transmitted infections like HIV. Also, the cost can be considerably less since eggs are shared to reduce the overall cost of the process, and potentially there could be more choice in terms of types of donors available. Where are we today? About 4 to 5 years later, the largest published study to report the success of egg donation using previously vitrified eggs is from the Spanish group who published the original randomized controlled trial that I showed. Recent data from their group of over 3,400 cycles in which they thawed between 8 and 15 eggs per recipient demonstrated that over 90% survived the thaw, and ongoing pregnancy rates per transfer of about 45%. ongoing pregnancy rates per recipient cycle were close to 40% in this study. Overall, the live birth rate per egg thawed was 6.5%. Interestingly, though, they and other studies have noted that a small proportion of cases are associated with very poor survival and cancellation, and sometimes these cases are unpredictable. So in this study, 1.4% of the thaw cycles had extremely poor survival and were canceled with no transfer. Unfortunately, it's difficult to predict these cases. So how does data from the U.S. compare to this European data? Well, in 2006, almost 1/2 of donor egg cycles in the U.S. were from frozen donor egg banks. When we look at data from the Society of Assisted Reproductive Technologies, the preliminary data from 2016, we can see that live birth rates per transfer using frozen donor eggs were about 44%, and live birth rates per cycle were 36% using frozen donor eggs, compared to 55% and 50% using fresh donor eggs. So you can see that in practice, even with donor egg freezing cycles, it appears the success of using frozen eggs is lower than using fresh donor eggs. Still, this is an effective technique for many patients. There are also more data accumulating on the success of elective egg banking. The EV group also published on their success with elective egg banking. In this publication, they reviewed their experience. In this study, almost 1,500 women pursued elective egg freezing at a mean age of 37. 137, or 9% of these women, returned to use the eggs about 2 years later. Overall, 85% of the eggs survived the thaw process, and overall, the live birth rate per transfer was about 31.6%. What they found was that the success really varied by age. In women less than 36 years of age, the success was much higher and seemed to increase as the number of oocytes obtained or thawed increased. So you can see the cumulative live birth rate continues to go up in this young population with the number of eggs thawed. In older women over than 35, the success rates were significantly lower, so about half as successful overall, and the cumulative live birth rates appeared to plateau at around 10 eggs. So even if women obtained many more eggs, the success rate was still not increasing. So I think these are important data for counseling women. Ideally, women should pursue elective egg banking when they're younger, because obviously, according to this study and other studies, it's more successful. So live birth rates per embryo transfer were similar when we look at data from a large U.S. program. In this study, 875 women pursued egg freezing, and 13% of those women, or 117 women, returned to thaw their eggs. Overall, 39% of these women had a baby per transfer, and overall, the success rate was about 6% live birth rate per frozen oocyte, so similar to the other studies. They performed statistical modeling in this study in order to estimate the number of eggs required in order to have 1, 2, or 3 children. And this was stratified by age, as you can see here. So, for example, if a woman froze 10 eggs at 30 years of age, she had about a 70% chance of having 1 child, less than a 30% chance of having 2 children, and less than 10% chance of having 3 children. And this was shown for each age group, suggesting that the older a woman is, the more eggs she needs to freeze. Now, clearly, these are small sample sizes in these studies, and more data are needed to give realistic estimates for patient counseling. But I think these estimates and modeling studies are helpful in order to give patients realistic expectations. Sometimes more than 1 round of egg freezing is needed to provide sufficient eggs for a woman's desired family size. So it's also important to recognize that there are very limited data on pregnancy outcomes from frozen eggs in cancer patients who froze their eggs before cancer therapy. This table presents results from a study published in 2014, again from the Spanish EV group. In this study, 11 women with a mean age of 35 froze their eggs prior to cancer therapy and came back to use them. Of the 11 women who thawed their eggs, 6 became pregnant and 4 had ongoing pregnancies. So looking at the numbers, 36%, again, it is similar to the previous studies on egg freezing in other populations, which is reassuring. But again, data in diverse populations like cancer patients are limited. We've also made tremendous progress in developing flexible strategies of stimulating patients without waiting for a menstrual cycle. Patients can get through essentially within 2 weeks now. I would recommend this review by Mitch Rosen's group at UCSF. Essentially, this diagram shows stimulation protocols at various stages in the menstrual cycle. Antagonist protocols are used, which provide flexibility for trigger with a GnRH agonist to avoid hyperstimulation. We usually use letrozole, an aromatase inhibitor, to suppress high estrogen levels in patients with estrogen-sensitive tumors like breast cancer, and it tends to work quite well. It's absolutely fine to start patients in the luteal phase and simply start antagonist when the lead follicles measure 12 millimeters. During the late follicular phase, either stimulation may be started and the patient allowed to ovulate on their own before starting antagonist, as long as all the secondary follicles are less than 12, or a trigger can be given with a dominant follicle measuring 18 millimeters, and then stimulation can be started 2 days later. Several studies and our own experience suggest that the number of eggs and embryos are similar when comparing random start versus conventional start protocols. It's also possible to do back-to-back cycles, starting stimulation in the luteal phase just a few days after retrieval. Sometimes this is necessary in cases where there's a poor egg yield and a patient has an urgent need to start cancer therapy. There's still very little information about the success of egg freezing in adolescents. Some of you may have had some experience with these patients, but I thought it might be helpful to give you some examples of how these patients do with stimulation. 2 of these are my patients, and 2 are from the literature. One of the youngest patients to go through stimulation was reported by the group at Cornell. This patient presented at 13 years of age with myelodysplastic syndrome, planning to undergo bone marrow transplant, and had not yet experienced menarche. She was given gonadotropin injections for 9 days, and a total of 20 eggs were retrieved. 18 mature eggs were cryopreserved. The other 3 patients were between the ages of 15 and 19 years of age. They all had undergone menarche already. 2 had lost an ovary due to ovarian cancer. They all stimulated well for about 2 weeks and got between 8 and 21 eggs. Neither of my patients had been sexually active, and one had never even used a tampon, but they were able to tolerate transvaginal ultrasound monitoring with a lot of care. And so it is possible for motivated teens to go through this process, although they definitely need a lot of coaching and support. Ideally, patients are seen prior to the initiation of chemotherapy, but sometimes we get calls about patients who've already started chemotherapy, and the oncologist wants to know if it's possible to stimulate the ovaries. Typically, this happens in the setting of leukemia, where patients are hospitalized and chemotherapy is quickly started because their blood counts are abnormal. So is it safe to pursue ovarian stimulation for cryopreservation during or after chemotherapy? I believe this is not a great idea. While it may be possible to stimulate the ovaries, there's definitely concern about egg quality. At least in mouse studies, in mice who've conceived within 3 months of chemotherapy exposure, they appear to have a lower implantation rates, higher resorption rates, and higher malformation rates in the offspring. So there's concern about DNA damage to the eggs. Patients definitely need to be counseled about these potential risks. Unfortunately, I know of no publications to date assessing pregnancy outcomes in women who freeze eggs or embryos during or immediately after chemotherapy. So there is concern. Occasionally, we've had patients have some time for ovarian stimulation between the time of initial chemotherapy for leukemia and bone marrow transplant, but I generally recommend waiting as long as possible, ideally at least 3 to 6 months, for the effect of chemotherapy to diminish. Again, we just don't know how safe this is. How about in survivors remote from treatment? Again, one question that's receiving more attention in the survivorship community is whether there is a role for fertility preservation in survivors. Ideally, we should be considering fertility preservation options at the time of the cancer diagnosis before a patient's been treated for cancer. However, some patients may not have had the opportunity to pursue any of these options before treatment. I've been seeing more and more survivors who are not ready to get pregnant, but who are worried about their long-term fertility after treatment. In survivors who have reasonable ovarian reserve, egg freezing may be an option and could be offered to survivors as a second opportunity to preserve fertility before they go through early ovarian failure. Again, there's very little data in this area on the success. While there is little information about how these patients respond to stimulation and the ultimate outcome, we recently published some data on this topic from our experience. In this study, we compared the response to stimulation in 35 survivors who had been previously exposed to chemotherapy to 95 newly diagnosed cancer patients. Most of these patients were freezing due to a recurrence of cancer or simply because they planned to delay pregnancy for many years and were worried about their long-term fertility. As expected, ovarian reserve, specifically AMH and antral follicle counts, were impaired in the survivors, and they were given a higher total dose of gonadotropins to stimulate their ovaries. 1/4 of the cycles were canceled and did not even get to retrieval. However, those whose cycles were not canceled got a median of 10 eggs, really no difference from the other groups. So it is possible to get eggs in cancer survivors remote from treatment. Again, the quality of these eggs is not known, given that patients generally have not come back to utilize these eggs, so more data are needed to routinely recommend this to survivors. So in summary, egg freezing is a great option for young women. We now can get them through the process quickly and safely. The major advantages of egg freezing include the fact that it is a proven technology, at least in young women, particularly in egg donors. It offers the possibility of fertilization and biopsy for pre-implantation genetic diagnosis and screening, which sometimes is important for cancer survivors who may have genetic predisposition to cancer, like BRCA mutations or Li-Fraumeni mutations. Embryos can eventually be placed in a gestational carrier for those who lose their uterus or are not healthy enough to pursue pregnancy. The major disadvantages of egg freezing include the fact that it's not possible to stimulate a woman's ovaries before the initiation of puberty. It is a complex process. It takes time, typically about 2 weeks. It can be expensive and not covered by insurance. It may not be safe or successful immediately after chemotherapy exposure. It's generally inefficient in patients with diminished ovarian reserve, and it's clearly not a guarantee of having a baby down the line. In vitro maturation has received some attention in the field over the past decade and refers to the retrieval of immature eggs after limited or no gonadotropin stimulation. Several different protocols have been described to retrieve the eggs, some using limited amounts of gonadotropin, FSH, HCG, or a combination of FSH and HCG. The advantages include the fact that stimulation can potentially be shorter, but many of these protocols still start with the menstrual cycle, so it really doesn't decrease the number of days substantially. There's potentially less exposure to estrogen, and that can be a concern for estrogen-sensitive tumors like breast cancer or endometrial cancer. It can be less costly because the amount of gonadotropin used is less, and there's a lower risk of ovarian hyperstimulation syndrome. Disadvantages include the fact that most of the data have looked at patients with PCOS, not cancer patients. And in general, success rates have been substantially lower with in vitro maturation compared to traditional stimulation. And now, given the more flexible random start protocols that were described, as well as the safety of the Lupron trigger, I personally have not found a great reason to offer in vitro maturation to my patients. I think that if more convincing data become available, this could be a more broadly utilized option. On the other hand, I believe ovarian tissue cryopreservation is a much more promising technique. According to the American Society for Reproductive Medicine, ovarian tissue cryopreservation should still be considered experimental and performed under an IRB protocol. This technique should be primarily offered to those who cannot pursue other non-experimental techniques such as embryo or egg freezing. Potential candidates for this procedure include prepubertal girls, females with hormone-sensitive malignancies, those anticipating stem cell transplant for any indication, or females with genetic mutations that pose a high risk for premature ovarian failure. The major benefit of ovarian tissue cryopreservation is that it does not require ovarian stimulation, so there's really very minimal delay in treatment. No partner is needed, and it can even be performed after exposure to chemotherapy if the chemotherapy is not a sterilizing dose. And most importantly, it's really the only option available to prepubertal girls. It does require surgical removal of ovarian tissue. Either an entire ovary or cortical biopsies can be removed from the ovary, typically laparoscopically. Generally, these fragments are processed into, the tissue is processed into small fragments, and then ultimately it can be either transplanted back into a woman's body, or theoretically, eggs can be grown in vitro and used for in vitro fertilization. So ideally, the tissue is removed before exposure to chemotherapy to maximize the number of follicles cryopreserved. But it can even be performed after some exposure to chemotherapy, as I mentioned, especially if highly gonatotoxic therapy is anticipated, like a stem cell transplant. Ideally, it can be coordinated with another procedure related to the cancer treatment. For example, many cancer patients need port placements or bone marrow aspirates or even tumor resections. And so this can be an add-on procedure. And by doing that, you can minimize the risk associated with anesthesia. Also, it's possible to combine the fertility preservation procedures. So you can remove ovarian tissue as part of an oophorectomy, where you're moving the ovary away from the radiation field. It's also possible to perform ovarian tissue cryopreservation even after egg or embryo banking. One consideration is that you do have to wait until the ovaries shrink, typically at least 1 to 2 weeks. You can see here a photograph of removing ovarian tissue in an unstimulated ovary. You can peel off the cortex, as you see, and you can see small follicles. Here's a small antral follicle under the cortex that's being removed. Here's a picture after ovarian stimulation. You can see the corpora lutea, but still you can peel off this cortex where the eggs reside, and this can be pretty straightforward. Typically, there's very little bleeding. One technique that can help is using a Lupron trigger, and it can help the ovaries shrink a little bit faster in these cases. After the tissue is removed, the tissue is dissected into small fragments, as you see here. One important consideration in children is the fact that often you need to collaborate with a pediatric surgeon, because most of us do not operate on children who are less than 8 or 10 years of age. And while the surgery is very similar, often, collaboration is required. So since the first live birth of orthotopic transplanted tissue in 2004 by Dr. Done, there have now been over 130 live births reported, according to a recent review article in the New England Journal of Medicine. And so typically, transplantation is performed by various techniques. One technique that has been described includes doing open surgery, so laparotomy, where you can decorticate the ovary, shown here, and then suture the thawed ovarian tissue fragments onto the medulla of the ovary using a microsurgical technique, and that's been described by Sherman Silber. This picture here is actually a fresh transplant between identical twins, but I think it shows very nicely how the transplant is performed. Another technique is performing a laparotomy and making incisions over the ovary and then tucking the pieces, cortical tissue pieces, under these little slits or pockets and then suturing the pockets closed. That was reported by the Danish group. And then another group, most often in Germany, has reported success by transplanting tissue under peritoneal pockets. So essentially in the ovarian fossa, a small incision is made in the peritoneum and then small pieces of ovarian tissue are placed within that pocket and the tissue can then develop. Done has reported a technique that's performed laparoscopically. Actually, the German technique is also laparoscopic, but this technique is where the ovary is decorticated and then the small fragments of thawed tissue are placed over the ovary. Here, an absorbable mesh inner seed is sewn over the ovary in order to keep the pieces intact. So how successful is ovarian tissue transplantation? The best data really come from the European groups. The largest series was reported by the Fertility network. They have 101 centers and they have collected over 2,500 ovarian tissue samples. They do that by collecting the tissue and then transporting the tissue to a central processing center where the tissue is cryopreserved. In this series, they reported that over 65% of the patients who had undergone autologous transplantation had hormonal function at 1 year, and 23%, or 17 out of the 74 women who had undergone transplantation, had had a live birth. They also reported that a subset of these, 9 of 40 women, or 23%, experienced a live birth with their first transplant in the setting of premature ovarian insufficiency after treatment. But no patient in their series had conceived after exposure to pelvic radiation. The Belgian, Spanish, and Danish groups have previously reviewed 60 transplant cases and reported that 11 out of 60 became pregnant, or 18%. These are a little bit older data. And then more recently, the Danish group, who has a nationally funded program in women less than 35 years old, who are high risk and good prognosis patients, all undergo ovarian tissue cryopreservation. In their series of 32 transplants, they reported that 31 had had live births. I think the success has been growing over time, so that's really exciting. However, an important consideration is that there really is no comparison group of untreated women. And so, at this point, all we have are case series of success. So heterotopic transplant has not been as successful as orthotopic transplant. Heterotopic transplant refers to transplantation of tissue outside of the ovary or pelvis. So in other words, tissue is transplanted to the abdominal wall, for example, the rectus muscle, subperitoneal spaces, the forearm, or the chest wall. The advantages of heterotopic transplant are that it can be possible to do this technique even in the setting of severe pelvic adhesions or radiation to the uterus and ovaries. So the surgery is generally easier. The surgery is less invasive, and it's particularly convenient if you have to do repeated transplantations. Since tissue does not last very long, often transplant needs to be repeated multiple times, and patients have to go through multiple surgeries. It's generally easier to recover the eggs from sites that are close to the surface of the skin, for example, rather than deep in the pelvis. And it's also possible to monitor the site closely for signs of malignancy or tumor growth. Unfortunately, IVF is required to conceive when heterotopic transplant is performed, so the success rates of IVF after transplantation are extremely low because of the very low ovarian reserve or number of eggs that are actually existing within the tissue. IVF success after transplant has been estimated to be on the order of 3 to 4% per cycle. In addition, there's really been much less success overall with heterotopic transplant. There's only been one live birth of twins reported from transplantation of tissue to the subperitoneal spaces in the abdomen, and that birth was reported in Australia, and to my knowledge, no other heterotopic live births have been reported. So what are future directions in transplantation? Someday it may be possible to transplant tissue to another woman in order to carry the pregnancy. This is an exciting area of investigation, and one group of investigators performed an allogeneic transplant of ovarian tissue in a baboon and reported evidence of ovarian activity with no rejection. Those baboons were treated with immunosuppressants. However, there has not been any live birth to date in animal models or humans, but I think there is hope that tissue eventually might be able to be used in a gestational carrier in a woman who can't carry pregnancy. And this is particularly relevant for cancer patients who may have been exposed to pelvic radiation, may undergo hysterectomy, or have other medical issues or comorbidities that make pregnancy unsafe for them. One of the biggest problems or concerns about ovarian tissue transplantation is the fact that it's not possible to screen ovarian tissue for malignant cells. We definitely need better methods to do this. This risk was first really highlighted in 2010 when there were reports of tumor cells present in tissue and growing in mice who had undergone ovarian tissue transplantation from 18 patients with leukemia. In those mice, they found that 50% actually had molecular evidence of tumor cells, and after 6 months of growth, gross tumors were noted in 4 cases. So that was a major concern. Since then, there have been a variety of reviews. Systematic review of 289 studies suggests that the greatest concern regarding seeding tumor cells is from cancers like leukemia or cancers that involve the ovaries, like ovarian cancer. Patients with BRCA mutations would obviously not be candidates for ovarian transplantation either, given the fact that they're at higher risk for developing ovarian cancer themselves. It appears that patients with lymphoma are the best candidates for ovarian tissue transplantation, and many of the successes have been in that population. However, whenever transplant is considered, it's important to work with the oncologist and determine potential risk that tumor cells exist within the ovarian tissue and the safety of transplantation. Recently, a live birth was reported from ovarian transplantation in a patient with leukemia. In order to screen the tissue, the investigators actually took portions of the tissue and transplanted them into a mouse model, grew the tissue, made sure that tumor cells did not grow in this mouse model over 6 months, and then after that, transplanted the remainder of the tissue into the patient, and she was able to conceive and have a baby with no recurrence of cancer to date. So hopefully in the future there will be better ways to screen the tissue so that transplantation can be performed. Because of the concerns surrounding transplantation of ovarian tissue, especially in leukemics, we and others try to freeze any immature eggs that we identify during the ovarian tissue processing. While pregnancy rates are likely very low from this technique, it may offer patients an alternative to transplanting ovarian tissue later on. One study found that germinal vesicle oocytes can be identified in 85% of ovarian tissue cases. A third of these immature eggs will mature in vitro, and there has been at least one live birth reported from such eggs. Young patients and those without previous cancer treatments are the most likely to have immature eggs identified at the time of cryopreservation. Ideally, in order to avoid transplantation altogether, we could figure out how to grow healthy eggs from very immature eggs extracted from ovarian tissue. Patients could avoid multiple operations and avoid the risk of recurrent malignancy from transplantation. Moving in vitro follicle maturation forward has been a major goal of the Oncofertility Consortium. Over the past 10 years, investigators working within this consortium have made steady progress. They've worked with bioengineers and have developed a process for encapsulating ovarian follicles in alginate. This has allowed follicles to grow in a more physiologic environment. They've grown human primary and secondary follicles in vitro and demonstrated antrum formation and reproductive hormone secretion. They've successfully triggered final maturation of the oocyte and obtained mature eggs from that. In addition, they were able to demonstrate that the oocyte could actually ovulate out of the follicle in vitro, which was pretty amazing. While live births have been achieved through in vitro maturation in the mouse, there's more research needed to make this a clinical reality for women, and this technology is still far away. The Oncofertility Consortium is a multidisciplinary research initiative that was spearheaded by Teresa Woodruff at Northwestern and initially funded by an NIH roadmap grant. It brought together basic scientists and clinicians to work together to move ovarian tissue cryopreservation technology forward. The goals of the consortium were to better understand mechanisms underlying the fertility threat of cancer drugs, to improve methods for cryopreservation, storing, and growing ovarian and gonadal tissue, to develop in vitro follicle growth and oocyte maturation using the 3D alginate structure that I showed, to bridge communication barriers between cancer patients and healthcare providers, and to explore ethical and legal concerns regarding the use of fertility preservation technologies in cancer patients. They've really made an impact in the field and spearheaded the clinical care and research. The consortium has expanded to 71 centers across the U.S. and over 50 global partners, and over 400 ovarian tissue samples have been collected to date. There are a variety of online and printed resources for patient and providers and books that have been published in the area. These offer really important resources to both clinicians and researchers in the area. I think that together, by sharing information among centers, and we can improve the knowledge and access to these services for our patients. We initiated our ovarian tissue cryopreservation in 2008 at the University of Pennsylvania and have offered it under an experimental protocol at the Adult and the Children's Hospital, initially through the Oncofertility Consortium. In this consortium, originally 80% of the tissue was stored for patient use and 20% was used for research, principally for in vitro maturation techniques. We have performed now over 90 ovarian tissue cryopreservation cases. Most of these have been in children less than 21 years of age. 60% of these patients had prior exposure to chemotherapy, so were not good candidates for ovarian stimulation or egg freezing. They often were patients where very high-risk therapy such as bone marrow transplant or pelvic radiation was planned. 90% of the cases were combined with other scheduled procedures like port placements or bone marrow aspirates. A few have been performed after ovarian stimulation, and I showed some pictures of that. And unfortunately, about 10% of patients have died after the tissue was cryopreserved. We are very lucky to have some philanthropic funds to cover pediatric cases. Insurance has covered some of the adolescent and adult cases in the hospital, typically covering the surgery. And as of now, we have not charged for the laboratory component or cryopreservation of the tissue, although if the techniques become more popular, this may be necessary. So in summary, ovarian tissue cryopreservation really does have a variety of advantages. It's the only option for prepubertal girls. It's a very simple procedure and poses little risk in terms of delay in starting therapy. It can be performed after exposure to a limited amount of chemotherapy. The disadvantages are that often multiple procedures are required to utilize the tissue in terms of transplantation. It's still considered experimental, and while the efficacy is promising, there is little long-term data, particularly in children utilizing this technology. Transplantation is a concern in terms of the risk of seeding cancer cells, and so that's really the major risk. And another issue is the fact that it's difficult to offer patients pre-implantation genetic screening or diagnosis, or offer them the option of using a gestational carrier, since IVF would be required after transplantation, and this has been shown to be very inefficient. So I think I've shared with you an overview of the field of fertility preservation. And now I'd like to switch gears a little bit and talk more about where research is taking us and where we need to go from there. So most of the research on fertility preservation has been in adult cancer patients. But as I mentioned in the beginning of the talk, there are a number of other groups of patients who could benefit from these techniques, such as children, girls with Turner syndrome, and transgender populations, just to name a few. There's very limited data in these populations. Families are particularly interested in pursuing fertility preservation in patients with Turner syndrome. Particular patients with mosaic Turner syndrome may be candidates for fertility preservation before ovarian failure occurs. Obviously, this population is tricky. They need to be counseled about the risk of having children with genetic abnormalities and the risks of carrying a pregnancy in the setting of Turner syndrome. A full cardiac evaluation would be necessary, and it may be advised to use a gestational carrier even in the setting of a normal examination. We need more prospective data on the natural history and reproductive options for these patients. Transgender patients are also seeing us more frequently to discuss the role of fertility preservation prior to going on ovarian suppression and androgen therapy. The benefits of ovarian tissue and egg freezing are not entirely clear in this population at this point, and again, more work is needed in this area to determine best options for patients. Ovarian tissue transplantation has also been advocated as a fertility treatment for women with premature ovarian insufficiency. There have now been several publications suggesting that it may be possible to activate residual primordial follicles in this patient population, but by removing the ovarian tissue, culturing it, and transplanting it back under the fallopian tube, and then doing in vitro fertilization. This was first reported by Aaron Shui's group and has been now replicated by others in the human. It's not clear if the mechanical disruption of the tissue somehow activates the follicles or the culture media that's used plays a role. Nonetheless, I think these are really intriguing data and very novel concepts that have the potential for future application for premature ovarian insufficiency. What about males? As you know, the standard of care in postpubertal males is to cryopreserve ejaculated or surgically retrieved sperm prior to cancer therapy. There has been a lot of interest in fertility preservation for prepubertal boys who do not yet have mature sperm. 15 years ago, Ralph Brinster reported that he was able to collect and isolate spermatogonial stem cells from prepubertal mice testes, transplant them into the testes of another mouse, and produce offspring. There are currently several institutions, including ours, who offer testicular tissue cryopreservation to prepubertal boys facing gonadotoxic therapies. So far, there has never been a live birth in humans, but hopefully continued research in this area will make that possible. What's more, incredible work is being done to actually make eggs and sperm from somatic cells. In 2012, stem cell biologists in Japan were able to reprogram mouse skin cells into primordial germ cells by combining them with embryonic or non-embryonic stem cells. These cells were then placed in the ovaries or testes of mice to mature them into competent eggs and sperm. Using IVF and ICSI, live births were reported. Last year, another Japanese group were able to perform a similar experiment, but were able to mature the eggs completely in vitro without transplantation. This also led to live births in mice, which were able to reproduce as well. This has tremendous implications for reproductive medicine. Imagine creating germ cells could allow individuals with gonadal failure to reproduce and may even enable same-sex couples to have biological children without having to use donated gametes. So while we have made a lot of progress in the area of fertility preservation, it's important to recognize that these methods are not perfect. Fertility-preserving technologies pose significant risk. They delay cancer therapy. They're costly, invasive. Some are still experimental. There are considerable numbers of ethical questions in children, especially related to who consents to these procedures. And the reality is the most likely patients to pursue fertility preservation are older, wealthier patients and those with early stage disease. But the real question is, who should we target for fertility preservation? Currently, strategies to predict the risk of infertility after cancer therapies are very limited. We and others have made some progress in helping to identify those patients who are at higher risk of infertility. We know that those exposed to alkylating agents and pelvic radiation are at the highest risk. Young patients and those with high ovarian reserve have a reduced risk, but we need more data to come up with an accurate tool to predict risk for individual patients. Finally, it's important to recognize that there are significant legal barriers to conducting reproductive research in the United States. The Dickey-Wicker Amendment was signed into law in 1996 and specifically prohibits the use of federal funds for human embryo research, even those derived from parthenogenesis. This makes any type of clinical or basic human IVF research extremely challenging. Therefore, more work needs to be done to change the current laws to facilitate needed research in the field. So in summary, there's no question that we have made great strides to expand the reproductive options of patients with cancer and other fertility-threatening conditions. However, more basic and epidemiologic research is needed to improve the safety, efficacy, and availability of these techniques and to develop new techniques to expand reproductive possibilities for all patients. Thank you very much.